Good afternoon. This is Stephanie Baum, Digital Health Editor with MedCity News, and you're watching MedHeads. I'm joined today by my colleague, health technology reporter Neil Versel in Chicago. Neil, how are you doing?
Doing great, Stephanie. Good to see you.
Good to see you. And I should say welcome back because you've been away for this week
Right.
at a very different that we're going to be talking about in this session of MedHeads, the American Medical Informatics Association. So Neil, for the uninitiated, you've actually been covering the health IT sector for several years now. How many times have you gone to this event?
Oh boy, I'd say at least 7 or 8 because it's been the way AMIA's rotation is set up. San Francisco is on a 6-year rotation, and I remember covering the last time it was in the same hotel, the Hilton in San Francisco. So, and I know I was covering AMIA before that, so I would say 8 to 10 years at least.
Okay, so paint a picture for us. What's the feel of this event like? Am I likely to see a lot of bioinformatics startups, big data analytics startups pitching investors, or am I more likely to see CIOs that have a big bullshit detector and don't suffer fools?
Right. Well, I think probably not a whole lot of either one. You do see a few startups around there, but this is an academic audience. These are medical informaticists, nurse informaticists. You see a lot of CMIOs rather than CIOs. Some of them are CIOs. You see some chief nursing informatics officers as well. These are pretty much everything they do is peer reviewed. This conference actually publishes proceedings, which has the feel of a medical journal. So, all the papers and posters presented are peer reviewed and, subject to probably a higher standard than you might see at some other conferences, non-scientific conferences. And yet, while it's a scientific conference, there's a lot in there for someone like us, MedCity News, which covers innovation, to be there and cover. I could probably mine the proceedings for the next 6 months if you wanted me to go through and find every study that's relevant to our readers. I'm not going to, but I could.
But since you've been going for so many years, how would you say that this year you noticed any particular changes, or you've noticed the conference evolving the last few years to any specific kind of area or territory that maybe you really didn't see that much of when you first started going?
Sure. I think digital health had a much more central focus than I would have initially imagined. Now, it's not the first time digital health has been mentioned in one form or another at AMIA. In fact, I remember the very last time this conference was in San Francisco in 2009. Mark Smith, who was the president of the California Healthcare Foundation at the time, got up and said, "Hey, why isn't there I can go on Open Table and book a restaurant reservation with my wife on Saturday night on 30 minutes notice, but I can't do that if there are any cancellations at my doctor's office. Why hasn't someone designed that?" Well, shortly after he said that, a company called ZocDoc came along, and there have been some others like that have done that can help practices fill canceled appointments and last minute appointments and that sort of thing. So it's been on the radar screen of the AMIA community for a long time, but now we're starting to see a lot of it filter into real clinical practice, particularly with the focus in meaningful use stage 3 on APIs and the focus by a lot of EHR vendors on extending their products with apps. One of the stories that I was very surprised to get was learning that Epic has actually trademarked the name of their upcoming app store, which they say will be probably online by the end of the year or early next year. They're calling it the App Orchard, which clearly is a nod to Apple, and clearly plays on the fact that Epic has, likes these sort of whimsical things. As if anybody who's seen photos of their campus or been to their campus up at Wisconsin knows, they have the Harry Potter themed campus. They have I can't remember the other themes, but they have, each campus has a theme. So.
Sure, and I mean, I just want to let's stick on that Epic story that you wrote this week. I mean, do you see a lot of other electronic medical moving in this direction of cultivating kind of an app store, or do you see them using kind of specialist contractors to do you, let me ask, do you see the model of that?
Well, I think they're the ones creating the app. The user community are the ones creating the app. I don't think it's a new idea. They also did say interoperability for it. Said that it will be vetting all the apps, which Apple does, and which he said Google did with Google Play for Android.
Let's move back to the there are other things you wrote about the conference. There are other themes that you made a note of. Digital health seemed to be a pretty big theme this year, as it is, in sort of every aspect of what we're covering. It feels like sometimes. Were there any particularly captivating people or insights that you heard at the conference?
Well, I think I like the case study that I did about Brigham and Women's Hospital trying what they call microblogging to help with care continuity. I think that was an interesting one. We heard from a hospitalist there who said that they just spent too much time trying to track down information on or try to track down clinicians in the hospital with so many different platforms, pagers, text messaging, emails, sometimes to a private phone, sometimes to an institutional phone, sometimes through the EHR. So they decided to create something for clinicians and patients to be able to share. And I think that's getting in the realm of social media a little bit, but it's definitely still considered digital health. I think there were some interesting case studies, in fact, on social media as well. I did a piece about how one researcher is trying to figure out gender identity and figure out the right way to mention gender identity on patient intake forms by mining Twitter to see what terms people are using, because gender identity is kind of a new issue for people who aren't in that community, I suppose. And I believe the Joint Commission has recommended that that there be a place where people can denote their gender identity if it's something non-standard, on the intake form. So hospitals have apparently been struggling to find a right way to do that. And again, this was a researcher who focuses on ontology, getting the terms to match up, and that's agreeing on ontology is a major hurdle to health information exchange also. So I think health information exchange played into all this. These researchers, the presenters of all these papers, and there were hundreds of presenters, sometimes 4 per session for some of the breakout sessions, plus a couple hundred posters, maybe 300 posters that were presented. They are looking for practical applications of some of these technologies. They're researching. So they're trying to tie it into, you know, how to make better patient care, or how to produce better patient care, how to perhaps, you know, create the interoperability that's lacking, how to optimize EHRs. These are all the things that are on the minds of CMIOs today.
Sure. I mean, one of the interesting stories I saw from you this week focused on you just mentioned health information exchanges.
Right.
You wrote about what sounded like a kind of an interesting documentary on this very subject. And let's see, it was by Dr. Kevin Johnston, called No Matter Where. And I guess he's the chair of biomedical informatics at Vanderbilt University School of Medicine. Interesting, because I would have thought health information exchange as a topic would be pretty dry as a documentary topic, and yet, you know, I was struck in your story that you said by this guy's reckoning, some audience members at showings around the country left in tears for this movie. Could you give some color on that documentary and
Sure.
some thoughts on it?
Sure. Well, it screened Monday night. It was actually, it required a separate ticket for attendees. So I think they're still trying to raise money to find a distributor. But they spent about, the budget for this movie was about $500,000, which is more than your standard institutional video. You know, it's got the budget of an independent film, and it was a feature length, I think 77 minutes. They wouldn't need to cut it down to 53 minutes if it were to air on PBS, like Escape Fire did a couple of years ago. That was the movie about, you know, based on some of the writings of Don Berwick about how about patient safety. That movie appeared in theaters at some film festivals and was screened at conferences and did eventually get a showing on PBS. But anyway, this movie here, No Matter Where, definitely has some strong production values. They spent some money on animations, computer animations that, you know, certainly made things a lot more digestible for a lay audience. And in fact, Dr. Johnson, who made this movie, said he wanted to make it in a way that his mother could understand. So, you know, he's really counting on getting the public interested in this. And, you know, some interesting anecdotes from that story. In a lot of disaster situations, and he did interview some people who treated people at the Louisiana Superdome after Hurricane Katrina, or during Hurricane Katrina. People would show up with bags of medicine, some of which were ruined by water, some of which, you know, were not labeled in any way, or they would show up at clinics after clinics set up in the field by the Red Cross and other relief organizations, just saying, well, here are the medications I'm on for my diabetes, for my high blood pressure, for my congestive heart failure, et cetera, et cetera. And they were stunned to think that you couldn't just go onto a computer and pull this information up. A lot of the public, I think 70% of the public, according to the movie, believes that because there are now computers in doctors' offices, well, there should be it means that everything's interoperable and that the record should be available to any doctor who wants them. And that's just, of course, not true. And, you know, the movie looked at 4 different ways in which health information exchanges have failed over the years, and they failed repeatedly over several decades. In the 90s, you know, what we call health information exchange now, in the decade ago were called RIOs, Regional Health Information Organizations, and in the 90s were called CHINs, was it Computerized Health Information Networks, or CHINs. So, you know, the acronym has changed, the idea has not changed. And the fact that very few have figured out a viable business model for these things has not changed in 20 years. And yet we're not going to be able to get to the interoperability that people want unless somebody figures this out.
And yet, you know, as we've both seen, there are all kinds of private companies that are developing workarounds this very issue. So do you think, was there any kind of were there any thoughts at that conference, either from the people speaking or from fellow participants that you exchange with, that, you know, any one solution is really gonna win out, or is it just gonna be a bunch of different workarounds on maybe on a less ambitious level?
I think it's going to be a bunch of workarounds on a less ambitious level. I think there were very few people who were excited about meaningful use stage 3. I mean, some people who were involved in writing the regs for stages 1 and 2, or involved in at least informing the development of the regs for stages 1 and 2, just think that maybe meaningful use has outlived its usefulness at this point, and that maybe the direction that HHS wants to go, even though they are now placing an emphasis on APIs in stage 3, they still think that it's just not going to happen. And really, there needs to be consensus among, somebody needs to maybe get all the vendors and all the providers together in a room and say, hash this out amongst yourselves. And possibly the other thing that needs to be done is a change in the payment models, value-based purchasing. Because right now, the incentive among providers is to not share data because, you know, they don't want patients going over to their competitors. As long as there's fee for service, you're gonna have that dynamic. And you know, the faster we can switch to value-based purchasing and take away the disincentive, the better, and the faster we're going to get to interoperability. I think Bob Wachter, who gave the closing keynote, did talk about that quite a bit.
Yeah, I was about to ask you about him.
Yeah.
He sounded like, I couldn't make up my mind when I was reading your article if he's a futurist or kind of the non, because he was very non-specific about what he thought the future of digital health would be. Right. Although that he was confident that digital health would be part of the future.
Right. Well, I think he was trying hard to play favorites in his talk. I know he showed some things. Well, first of all, he called him kind of an outsider among these informatics, and yet this is something he wrote earlier. I think came out at the beginning of the year, maybe late last year. His book called The Digital Doctor. So he's definitely up on this topic, even though he considers himself an outsider. He said that he now believes that, you know, I mean, he's sold on digital medicine. He believes that right now we are in a, you know, that we're in a digital world now, and he thinks that stage 1 of meaningful use had a lot to do with that, because now there are electronic records everywhere, at least in just about every hospital, if not in every physician practice at this point. But you know, a lot of work still needs to be done. He is, you know, believes that there needs to be, we need to figure out the interoperability problem, figure out the usability problem. He did show, and I put it in my story, a slide from an ad that he saw for a new freestanding ER in the Phoenix area that opened a year ago. The advertisement looking for an emergency physician was hyping the fact that they don't have an EMR. So the fact that there is no EMR is a selling point for docs wanting to work at this freestanding ER. And he just believes that shouldn't be happening in, well, it was 2014, now 2015, almost 2016. And yet they call themselves a modern boutique hospital. Modern boutique hospital that still uses paper. That doesn't make any sense, does it? He was very, and then on the usability, the one other slide that I showed was a drawing of a 7-year-old, from a 7-year-old, of her depiction of a visit to the doctor, where she's sitting on the exam table, her family is sitting in chairs off to the side, and then the doctor is facing away, looking down at a computer keyboard. And Wachter joked that he said it's an incredibly accurate picture except for one thing: the doctor is smiling. So
that made me groan. I mean, I don't know how many times I've heard a quote like that in like the last year or something. But I mean, it's like, so is he groaning because
it got
he's
good
looking at
laughs
a
in that. It
computer
got good
and not
laughs in the room. It got good laughs in
What?
the room. It got some good laughs in the room to that audience.
Yeah, that's probably the first time I heard that. They don't have to go to all the conferences that we do.
Well, yeah, that's true. Yeah,
That's
true.
the sort of the downside, is that you tend to like, things get recycled a lot. But
Yeah, well,
I mean,
yeah.
so is the lesson from that? I guess my question is the lesson from that you know, he's unhappy because he's looking, is he supposed to be unhappy because he's looking at a computer screen rather than the patient, or that the state of interoperability or the state of digital health is such that it just falls short of what it's supposed to be?
Well, I think the doctor's probably unhappy because he has to key in information, updating patient history. The patient should be unhappy that the doctor's, maybe not a 7-year-old patient, but an adult patient would be unhappy if the doctor spent the whole time looking away from them. In fact, my own mother has told me that she felt like the doctor wasn't paying attention to her now that there's a computer there. So, and I've heard that from other people who aren't in the healthcare industry. But it comes down to usability, and EHRs are, and Walker did go on to talk about alerts and alert fatigue, and he said that whoever figures out alert fatigue, a fix to alert fatigue, should win a Nobel Prize, and that got some cheers from the audience.
Yeah, well, that's been a huge problem. I mean, I remember,
yes,
like, one of the first things I wrote about, like the technology hazards from the Korea Institute, that was like at the top of the thing. And I thought, like, what the hell is alert fatigue? Like,
yes.
And I just, and then I thought, like, surely, like, yes, it's like crazy, like the ICU is a crazy place, but they tune, you can filter what the correct alerts to listen for are, and what the ones that you can tune out are, or is it?
Well, he showed some screenshots, and he said that and this is a big problem that I did not touch on in my story, that I may touch on in another story coming up, because it's a bigger story than just what Bob Walker talked about, is that he showed a couple of screenshots from an Epic implementation where there was a nearly fatal overdose to a teenager, because I believe under 90 pounds or under a certain threshold, there has to be weight-based dosing, and I believe that's a Joint Commission recommendation. So there's weight-based dosing. So instead of entering the patient after a check caught a potential error, a check between a doctor, the prescriber, and the pharmacy, and the nurse administering the drug, caught or had a question, an alert came up. I think it went back and said, well, we have to go and put this, it was a rounding up of the number of pills to be given. And instead of putting in the patient's, the number of pills to be administered, the patient's weight, the entering physician then went back and entered 38.5 pills to be administered instead of 38.5 kilograms as the patient's weight. And all because the alert, this potentially critical alert, looked just like every other alert that doctors and nurses and pharmacists routinely ignore. Now, and then Walker talked about how
Make sure that we've got the gist. This is an alert that comes up in an EHR, correct?
Yes.
It's
and he said that he actually had to get permission from Epic to put the screenshot up, and that's another thing. There's a lot of the vendors are very reluctant to let the screenshots out in the public, even in the context of error reporting. And that's something I'm gonna go into in more depth in the very near future. But why do the alerts look the same? And he wasn't singling out Epic necessarily. He was just showing what he had access to in the system that was in use at this particular hospital where this problem came from. But he said this is true in many EHR systems where all the alerts look the same, whereas in an airplane cockpit, there are 3 levels of alerts. This is what some engineers at Boeing told him after he toured a factory. If it's a critical alert that could cause imminent catastrophic failure, crash or an explosion or something that could create a disaster, there are red flashing lights, and the control stick shakes in the cockpit, and that's the only place in the entire cockpit you're going to see the color red at all, according to what he heard from Boeing. So it's clear that if you're flying a plane, the alerts you're going to know if something is critical or if something is maybe secondary that you can work around for a while and maybe come back to later. But I don't think that's true in hospitals, that if there's a potentially fatal error or a potentially very harmful error, you're going to get any different warning than something that really turns out to be a nuisance alarm. I can't hear you.
We're coming towards the end of our half hour.
Yeah.
So
Yeah.
I just want to make sure that we do our weekly picks for our favorite stories of the week. Neil, what was your favorite story of the week?
I want to say the one about the movie was interesting, although the one that I posted early this morning about PricewaterhouseCoopers report on the future of primary care, which came out Wednesday, and that was the last day of AMIA, so I had to cover the conference for most of the day and then fly home in the evening, and I also was at a 3-hour disadvantage from the rest of you in terms of deadlines by being on the West Coast. That one, because I missed the chance to post the straight news story on the day that it came out, I decided to look for a different angle, and I went for, okay, here are some digital health aspects of it, and the story appears to be our most popular today. So, yeah, I think people are interested in digital health more so than okay, here's what people think what primary care might look like in the future, at least among our audience.
Well, I think
you
also
had a story.
they like our audience likes having the sort of the non-straight story. They know us for our unique viewpoints and in-depth sort of insight and analysis about the stories that we cover. So there's that too.
Yeah, I wish we could be as irreverent as our colleagues at Breaking Media colleagues over at Above the Law, for example. If you're in the legal business, go check out Above the Law. That's also published by our parent company, Breaking Media. They are extremely irreverent all the time, and we've been irreverent plenty of times. I see that neither of us has a beer in front of us today, but because we still have work to do. But we've gone there in the past. So
anyway, I'll just chime in.
Your favorite story. So
right. Actually, it was a company called My Health Teams. I wrote about this company feels like a few years ago when they were just kind of starting out, and they're basically developing a series of patient communities focus. I mean, they don't actually, they studiously avoid the word patient, and they focus on communities for people with chronic conditions. And when we first started writing about them, I think they just had like a few of them, and the one I wrote about, I think was the latest edition at that time, was they had a network focusing on people with breast cancer, and just the whole idea is to like some other companies in this area have discovered, is the value of making people with a chronic condition to reduce their social isolation and share insights, helpful information, and just making people feel like that they're not alone in dealing with their condition, that there's someone you could reach out around the world pretty much. I think they have 8 countries in their network aside from the US.
Oh, cool. Yeah.
And so to make them feel less alone and erase all the geographic parameters. They just added CVS Health as a strategic partner. that's a deal for them. And they're planning to add.
Doesn't it seem like that CVS and Walgreens are kind of divvying up all the companies here, and they're all competing?
Sorry, I missed that.
CVS and Walgreens are the big prize for a lot of these digital health companies. They're sort of racing to, get into. I mean, because they're enormous. Now, Walgreens is buying Rite Aid. It's going to be even bigger.
Yeah. So yeah, they're planning on growing to, I think, about 30 digital health, 30 chronic condition communities. I think they're adding another community dealing with hemophiliacs and another community dealing with food allergies next year. But I see we've come to the end of our half hour. So thank you for joining us for MedHeads. This has been Stephanie Baum and Neil Versel in Chicago. Have a great weekend.
Have a great. Oh, and by the way, we're not going to have MedHeads next Friday because of the Thanksgiving holiday.
Good point. Thank you, Neil.
We'll see you in 2 weeks.
That's right. All right, take it easy. Have a great weekend.